The phenomenon of delayed wound healing in the geriatric population is a multifactorial. To understand why a lesion on the tibia heals significantly slower than one on the thorax or upper extremity in the same individual.
The healing process is fundamentally an energy-dependent, oxygen-critical cascade of cellular events.
The primary antagonist in this scenario is the hydrostatic pressure column.
While evolutionary adaptations, such as the calf muscle pump and venous valves, have developed to counteract this force,
When we consider the physiology of the elderly specifically, we are observing a biological system where the margin for error has eroded.
In the elderly, however, the vessel walls have undergone structural changes, arteriosclerosis and atherosclerosis, which alter their compliance. This reduction in arterial compliance means that the perfusion pressure reaching the distal lower extremities is often barely sufficient.
A wound acts as a metabolic sink. It requires a massive influx of glucose, oxygen.
This ischemia is often not severe enough to cause frank necrosis in intact skin. But once the skin...
Furthermore, the problem of supply is compounded by the problem of drainage. The venous system in the aging leg is frequently plagued by valvular incompetence. When these valves fail, blood refluxes toward the feet, pooling in the lower legs and increasing the intraluminal pressure within the venules and capillaries.
The consequence of this venous hypertension is the leakage of fibrinogen and other macromolecules from the...
Even if oxygen is present in the capillary, it cannot effectively diffuse across this thickened, fibrotic pericapillary layer to reach the healing tissue.
This gravitational disadvantage is further aggravated by the anatomical reality of the skin overlaying the tibia and the ankle.
This creates an area of high skin tension and poor cushioning. In the elderly, distinct dermatological atrophy.
When trauma occurs in this region, there is very little slack in the tissue to allow for contraction, which is a key phase of wound healing. This reliance extends the healing timeline significantly. Moreover, the proximity of the skin to the bone.
The lack of a robust vascular bed underneath the wound floor means that new blood vessels, angiogenesis, must migrate.
While the macroscopic forces of gravidynamics. To understand why a leg wound persists for months or years in a senior patient, we must investigate.
In a youthful physiological state, the wound healing cascade is a tightly choreographed performance.
Neutrophils arrive first to sterilize the wound, followed by macrophages which clear debris, and then...
In the aging lower limb, this switch is broken. The macrophages recruited to the wound site and...
Instead, they linger in the wound bed as persistent inflammatory sentinels. These chemicals, which are necessary in short bursts to fight infection, become corrosive when present chronically.
This immunological dysfunction is compounded by the specific failure of the fibroblasts, the workhorse cell of...
However, in the skin of the elderly lower leg, fibroblasts exhibit a phenotype distinct from those in...
But the problem goes deeper than a simple lack of division. These aged fibroblasts in the lower extremity.
In the geriatric leg, even if the clinician applies advanced wound care products containing these growth factors, the aging fibroblasts...
Furthermore, the collagen they do produce is often disorganized and structurally inferior. Instead of the robust...
We must also consider the profound impact of the neurological system, specifically the length-dependent deterioration of peripheral...
Because of this extreme length, they are the most metabolically demanding and the first to suffer from the cumulative metabolic stress of aging.
The loss of protective sensation is catastrophic for wound prevention and healing. A senior individual may sustain a microtrauma.
Without the pain signal to trigger a behavioral change, limping or offloading the area, they continue to walk on the injury, essentially traumas. However, the sensory deficit is only half of the neurological equation. The autonomic deficit is equally damaging.
Furthermore, the autonomic nerves control the microvalves inside the blood vessels that direct blood flow to the skin surface to regulate heat.
Finally, we must address the depletion of the stem cell pool. The epidermis is maintained by stem cells located in hair follicles. Having dissected the hemodynamic burdens and the microscopic failures of the aging lower limb, the recalcitrance of lower extremity wounds is inextricably linked to the burden of comorbidities that accumulate with age. This thickening creates a rigid, non-compliant microcirculation. Furthermore, hyperglycemia causes the
This vascular compromise is frequently exacerbated by congestive heart failure habits. In CA,
This leads to massive third spacing of fluid, peripheral edema. But clinically, the management of this condition creates a paradox.
Beyond the mechanical and vascular, we must confront the anorexia of aging and the profound impact of nutritional deficiency on wound closure.
When a large wound is present on the leg, the body prioritizes the wound and begins to break down skeletal muscle.
Additionally, micronutrient deficits play a silent, distinctive role.
The pharmaceutical burden, or polypharmacy, is another distinct variable.
We must also integrate the psychological dimension, the stress of chronicity. Furthermore, wounds on the lower extremities are uniquely disruptive to sleep. Ischemic pain.
Finally, the environmental exposure of the lower limb cannot be ignored. For the elderly patient with limited flexibility due to spinal
The lower extremity is the furthest outpost of the cardiovascular empire. As the empire crumbles with age, the